So first, thanks, Sam, for inviting me. And so I do have kind of a strange background. So I'm emergency medicine residency trained, and then did fellowships in both surgical critical care and medical critical care. So I've kind of got a pretty unique training background, and throughout all that, I've somehow been tapped as the ultrasound person in our group as well. So I don't have an ultrasound fellowship, but I am one of our ultrasound people, and we'll be getting boarded in both abdominal and cardiac this year. So it's kind of my background, and so my big interest is ultrasound. So your objectives for today, so we're going to talk a little bit about just the background of HEMS, or pre-hospital care, and ultrasound, and some of the what's out there in the literature right now to get a kind of a base for where we're at. And then just talk about some basic ultrasound concepts and applications for you guys. What are the things that you're going to be able to use when you do finally get those machines that I'm sure you've all been promised many, many times. And then just, we're going to go through a couple different cases, and these are actually some cases that all that I've seen in the last year in the CCRU, a couple of which Sam brought me. So I may have taken a little bit of spin off of some of the things that he did or did not do for the patient, or questions that he asked me about it early. So those are things that we're going to do today in the hour that we have. So I kind of just want to talk about, and these aren't even really controversies, but more about talking points about what ultrasound can bring to the pre-hospital or helicopter EMS community. So is it applicable in trauma and non-trauma? And that's actually been studied in both services. Are we talking about pre-hospital transport or inter-facility transport? Are we talking about in-flight or on the ground? Obviously, there's going to be a huge difference between trying to scan in the helicopter versus in the patient's room if they're in another facility, or on the ground if it's a trauma or something like that. And then a little bit about physician, non-physician. I think it's pretty much been proven in all the literature that non-physicians can scan. The only reason I bring this up really is because most of the places that do a lot of pre-hospital ultrasound are actually done in places like the Netherlands and Australia, where there are physicians in the helicopters already. So that's why I mention it. I obviously think that the best sonographers in the hospital are the non-physicians, the ones who actually do it full time. So there's no reason to think that you guys can't do this as well. And then the whole idea of stay and play versus scoop and run. And this is something that constantly, it's not just ultrasound, right? But if you're a 15-minute flight away versus a 50-minute flight away, the things that you're going to do, whether it's before you take off with the patient or while you're in the air with the patient. To talk about those things a little bit as well. So just a little bit on the literature about what's out there right now. And there's really not much, not surprisingly. But kind of the overall thing is that this in-flight ultrasound is possible. It's feasible to do, okay? And you're gonna, kind of the first studies were done in the early 2000s. It said that it's feasible. There's no complications with the avionics, okay? And then this was really a variety of users: physicians, non-physicians, residents, fellows. They used it in a bunch of different helicopters. And they had simulated patients, they had real patients, and all it really was an observational setting saying, yes, we can do it, there's no complications, the helicopter doesn't crash. Shocking. I'm sure you guys are really surprised about that. So about a year later, they came out with kind of the first study that said, when you're doing in-flight ultrasound, a little over 50% are going to be adequate. And so really what this was talking about the FAST exam. And when they say adequate, the biggest limitations were space and time. Space being the main one. So people couldn't get around. They couldn't turn the patient very much to kind of get back sometimes. When you're kind of looking at the left upper quadrant, you really have to get posterior and pretty high up. And that's pretty difficult to do in a small area. And some of the cardiacs can be difficult too. We have the luxury in the ICU of being able to sit the patient up or turn them onto their left side and move the patient quite a bit in the ICU. And you guys don't have that capability. So this number, kind of around 50, 60%, I actually think is a really good number. So in half the patients are going to be able to answer the clinical question that you have. And I think that's a pretty important, powerful number. So it's not 100%, but guess what? It's not 100% in the ICU either. There are plenty of times where I have to say, I can't get this. I need a transesophageal echo or whatever it is. So this is actually a really pretty good number. Some more literature. This was 23% complete, and this was because they were limited mostly due to time or space constraints. But this actually showed that up to 90% of the studies that were actually performed are adequate. So that means that you guys can do this and actually get the images that you need. And I think that's one of the big studies. And then this more recent one really talked about thoracic ultrasound, really looking at pneumothorax and lung sliding. I tried to move the slide up as much as possible, but we had some problems with that. So then just talking about some pre-hospital stuff, and this is where we start to talk about outcomes, okay? So first, it would be great to show that there's a mortality benefit, but the studies aren't even near there yet, right? But we really want to know that we don't delay transfer and we don't cause any problems with ultrasound. And I think that's all been pretty much proven in the stuff that's been done so far. So kind of the first review talked about all of the studies that were reviewed showed benefit. They all had a large amount of bias, right? They're like, I'm here lecturing you today about ultrasound because I do ultrasound, because I believe in it, right? So all these studies that have been done so far are by people who really believe that ultrasound has the possible applications in pre-hospital setting. And then another one, this was just a couple case reports talking about a couple crews that went out, did their ultrasounds, and completely changed the disposition, right? So they got there, they didn't echo because the outside hospital didn't know how to do one, right? And I know that you guys have been in that setting where you're like, I know way more than this emergency physician or this ICU physician, right? You guys have been to those hospitals before, right? And so this actually has a huge utility, right? So really these case reports are about, they called ahead, called the provider, whether it's me or Lewis in the CCRU, and said, hey, this guy isn't as billed. They diagnosed a PE in one, and so that the patient was ready to go on VA ECMO when the patient got there. And the other one was an aortic dissection. So, and that was actually a similar case to one we saw in the CCRU. So somebody who presented a little bit differently than they had initially expected and actually saw the dissection flap on their echo, okay? So you can imagine, like, I need to call my cardiac surgeon, like, immediately and have the OR ready to go, right? Completely changes patient care. So you can't do randomized studies about these, but clearly the application is there. And so hopefully I don't have to convince you too much more of that, otherwise you guys wouldn't be here, okay? And the last one was just a trauma review study, and this just talked about it has a huge ability to change management in the field. So whether they're transferred to a level 1 trauma center or the local facility, right? Obviously hemodynamics are a really easy decision maker, right? But sometimes if you have positive ultrasound findings or concerning ultrasound findings, you may send somebody to a level 1 trauma center that you wouldn't otherwise, okay? So that's some of that stuff. And this is like the old school sauna site, like nothing like what's over there today. I am amazed by what we have now. All right, so what are the take-home points that I took from the literature review? Well, there's not much out there, so I think there's a huge possibility for more to be studied. But I think it's feasible. I think thoracic and abdominal is the most well-studied. Not a lot of echo stuff has been done out there, which is kind of my big thing, so I think there's huge possibilities there. Limitations are time and space, but you guys know that. You operate in this system every day. You know that your limitations are time and space. So that's nothing different or different than what you already know. And the last thing I want to talk about is that positive ultrasound studies have higher clinical value. And that doesn't mean like the literature studies. I really mean like you're sitting in front of a patient, you do a study, and it's positive, right? Your echo shows a pericardial effusion. That has way more weight than a negative study, okay? And that's what all of the literature talks about. So when you do have a positive study, that's what has the probability of changing management or changing your transfer, your disposition, whatever it is, okay? So really think about that as we go forward. All right. So that kind of brings us forward to this, and this is critical care ultrasound, and this is what I do. This is a little bit about like emergency ultrasound, but I think critical care even more so is about what's in front of me right now, the patient. What's the one clinical question that I have? You know, do they have a pulmonary embolism? Do they have a pneumothorax? Am I going to put a chest tube in? Do they have blood in the abdomen? Do I need to do a surgery, okay? This is all very pointed questions. These aren't anatomic surveys. We're not doing full abdominal ultrasounds, right? We're wanting to ask specific clinical questions because based on that answer, you're going to change your management, right? You're going to either start a fluid or give a vasopressor or do something else for the hypotension. And that's what critical care ultrasound is, okay? This is not sitting with the tech in the office for 15 minutes, okay? This is asking a very specific question, all right? And so as you kind of think about that, there's only a limited amount of clinical scenarios that you guys focus on, right? The patient's hypotensive or the patient's hypoxic. And so you can really focus in your skills on those things. So I think being able to do this is very, very attainable, okay? So there are a bunch of shock protocols out there depending on what you look at, okay? Kind of some of the more famous ones are the things like the RUSH, the rapid ultrasound in shock, the core exam, free exam, which was started at Shock Trauma, and obviously the fast exam. They all have different clinical applications. But I think protocolized care, like you guys know, is really, really good when the patient's sick. So you go through your protocol, make sure you dot all your I's, cross all your T's, and you get to a point where you've answered your clinical question, okay? These things can be tailored and truncated to the patient's clinical scenario, okay? But it's all about having a systematic approach to diagnosing the patient with hypotension, okay? And if you guys have questions as we go along, you don't have to wait till the end. Feel free to raise your hand or ask questions, okay? All right, so here are some of the things that we do right now, and I think are very, very pertinent to what you guys do. So talking about cardiac ultrasound, so is the patient hypotensive because they're in cardiogenic shock because they've had an MI? Or is it because they have a PE? The right side of their heart is huge and their LV is not filling now, right? You treat these patients very, very differently than you would otherwise. Do they have a pericardial effusion or are they hypovolemic, okay? And then lung, we're really, really looking at pneumothorax, and we're going to do one of those cases today that we're looking at some lung ultrasound. We're actually going to do all this stuff today. And then also some abdominal imaging, particularly for intra-abdominal hemorrhage for trauma, but also has some non-trauma applications, as you guys will see, okay? I think there's some other things that we'll scatter in here today as well, but these are kind of the main clinical applications that I think everybody in this room should be able to do in the future. This is not going to be like how to do all of ultrasound in an hour. That's not going to happen, but this is really to hopefully get you guys an idea of like what is possible to be done and hopefully get a couple learning points, okay? So our first case is just going to be a blunt trauma. All right, I know some of you guys do trauma, some of you don't, and that's okay. But we just want to talk about some of the applications, all right? So 20-year-old male is in a motorcycle collision in a rural area. He's altered with head trauma. He's agitated and combative. His GCS is about an 11. His abdomen's tender. He's tachycardic, but he's not hypotensive. And then he has right thigh and right upper extremity deformity. So it seems like a lot of the trauma is on his right side. All right? So the first responders call for flight to the level 1 trauma center. They're like, he was agitated, he's combative, I'm worried about head trauma. I want him to go to the level 1 trauma center, okay? Questions about that? All right, so flight crew arrives. One of you guys, or multiple of you guys get there, okay? These are his vitals when you get there. Still pretty stable, but tachycardic, right? So could be tachycardic from a whole bunch of different reasons. Can't rule out shock at this point in time, right? Remember, tachycardia is grade 2 shock or hemorrhagic shock, right? So, but he's agitated and combative, and you don't want to go into the air with him agitated and combative, so you intubate him. Yeah, his GCS is an 8, but that doesn't really matter, right, when he's fighting you. We all know that, okay? We all work in that clinical scenario. Trust me, I don't have to deal with him in a helicopter, and if he's acting like that, we still intubate him at shock trauma if you guys have spent any time there at all. Like, if they say 2 curse words, they get 1's for free. 2's not so much, right? You guys have to be able to take care of the patients, right? And so you intubate them. So get a good end-tidal CO2 waveform, right, which is the best confirmation that you have that the patient is intubated, the tube's in the right spot. Sats are 98%. You put in an 8-0 ET tube, there's 24 centimeters of the teeth. These are your basic vent settings, high fives all around. You get them packaged up into the helicopter. Questions about where you're at right now? All right, cool. Anyway, all right, so this is what happens in flight. His sats start dropping. He's in the low 80s. Your end tidal's still 36, okay? Heart rate's 124. Blood pressure is a little bit lower, but he's not frankly hypotensive. What's your next action? You're gonna bump up your FiO2 to 100%? Okay, everyone, oh, is that a reasonable course of action? Sure. You're gonna turn your PEEP up? What are some other possibilities? What lecture are you in right now? Oh yeah, you're gonna do this at ultrasound. Okay, yeah, sweet. Because you guys have those, right? So this is what I would do, right? So this is what I would do in the trauma, and this is what you guys can do as well when you have the technology. This is not a difficult thing to do. So let's talk a little bit about how to do a thoracic ultrasound, okay? So you can really use basically any transducer. Depending on who you are and what your biases are, you can use the linear transducer, curvilinear transducer. The Sonocyte guys have all that stuff here today, okay? And I have no disclosures, financial disclosures as well about that. So what you're going to do is basically going to orient the transducer towards the patient's head. So by convention, the indicator is always towards the patient's head or the patient's right-hand side unless you're doing echo, okay? So this is basically what it looks at. So patient's head is up here, patient's feet are down here. You're looking down through the ribs, all right? So what sits beneath the ribs is the pleural interface, right? We have visceral and parietal pleura. And what lung ultrasound really looks at is, it can't look at the lung because the lung is air-filled, right? And so ultrasound waves they get scattered when they go through ultrasound, right? Or when they go through air. So you can't see anything back. But what we're really looking at is that the 2 pleural interfaces are in contact with each other, okay? So that's what the lung ultrasound is, really pleural ultrasound, unless there's fluid in there, okay? So this is going to be kind of what we're looking at here. So, so this is a rib. It's casting a shadow. Rib casting a shadow, okay? Exactly what this shows. And that's our visceral pleura on this side, parietal pleura there. And so what we want to see is that those 2 are sliding against each other, okay? Hopefully this works. Sweet. So this is what's called lung sliding, when the two pleural surfaces are sliding against each other. And what you can see is a couple different things. One, you see an A line, which is a reflection of that interface here, but you also see these guys coming off, which are B lines. If they go all the way up, or comet tails, if they go all the way off the screen, they're B lines, okay? That's not important for what you guys are doing. That's kind of more advanced lung stuff. What you want to know is, are these two surfaces in contact with each other, okay? So that's what you're looking at there. So that's just an example of lung ultrasound. So let's go back to our case for a second. So this is the guy's right chest, okay? So not as clear of an image because this gentleman that we did this on was not small. So we're using a different transducer. It's actually the curvilinear, okay? But what we're going to see here is we see rib here, pleura here, right? Pleura always is going to sit in between those ribs. And you can't see anything beneath the bone because it's going to reflect all your ultrasound waves, okay? So this is his right chest, all right? And what we want to see is sliding again. So we see sliding there, right? So that means no pneumothorax. If the two are in contact with each other, sliding back and forth, it means there's no air in between, so you don't have a pneumothorax, okay? So there's been a bunch of studies that are out there in the trauma literature. When you compare ultrasound to AP chest x-ray, which is what we do in the trauma bay, right? The patient is AP supine x-ray. Ultrasound performs better. Obviously, the more spots that you do, look on ultrasound, the better your performance of ultrasound is going to be. But when the patient's going to be laying supine, air is going to go superior, right? Air is going to go up. So you would want to image basically anterior chest if you're only going to do 1 point. Obviously, more points is going to be better. Your space and time limited. I get that stuff, okay? But it's the same spot that you would basically needle decompress somebody, right? Second or third intercostal space, mid-clavicular lane. That's the most anterior or superior portion when the patient's supine, okay? Questions about this image? Lung sliding. All right. So you can guess what's on this slide, right? If last one was lung sliding, I'm probably not showing you lung sliding again, okay? But what we're going to see here is rib, shadow, pleural line is here, pleural line is here. And you see a little bit of movement there, and some people get thrown off by that movement. That's the intercostal muscle moving. That's the chest wall expanding, right? The patient's still breathing on that side, but the lung isn't sliding right there, okay? Lung sliding means no pneumothorax. No lung sliding could possibly mean pneumothorax, all right? So, based on that, how many of you guys are like, let's needle decompress this guy on that side?
Well, he's not tension.
Well, he's not tension, right, okay? But he suggests that maybe he has a pneumo. There's a little bit more to this than just that, okay? And he's positive pressure ventilated, yep. So I'm just going to compare these here real quick, just so you guys can see the difference one more time, what the two different sides look like. Everybody see the difference there? You have to see a few of these. This may be, how many of you guys have never done any of this stuff before? So at least half of you. So this is like going to be like first time seeing it. That's okay, you're not going to be masters at this, but just to understand that even your first time, you can see a difference in between the two. All right. So you're like, well, I don't see lung sliding on that spot, but Haase told me I want to look in multiple spots just to be sure, okay? So you're going to slide down a little bit. You're going to look at another spot here, okay? And this is something that's kind of one of my favorite things. So you see rib here, pleura here, but you really don't see sliding, right? It almost looks pulsatile, right? What's causing it to move? Not the airspace. The heart is causing it to move, okay? So if the heart is pushing on the lung and it's causing this movement, it means that the lung and the chest wall have to be in contact with each other, okay? This is what's called lung pulse. Lung pulse is 100% specific for no pneumothorax at that site, okay? So you cannot be seeing this. You cannot be seeing the heart pushing on the lung against the chest wall if there's air there, right? Air would cause nothing beneath it. So lung pulse means no pneumothorax, all right? So now you're saying, well, he has no lung sliding, but his lung is clearly in contact with the chest wall. So what causes no lung sliding? So let's go through our differential diagnosis. Oh, so we're going to do a couple more things. Sorry, before we do that. So this is another example of lung pulse, okay? So we're actually going to do something called M mode, which is where you basically take the cursor, you run it through a single point, and you look at this point for a period of time, okay? And you're looking for something called either sandy beach or barcode sign. Sandy beach is kind of this, you're looking off into the water and you see all the waves and nice ripples, and it's kind of very, very pixelated like the one on the left here is, okay? And so if you actually, it's going to be hard to see for you guys. if you actually look, there's kind of a rhythmic movement of the lung at this point in time. Just one sec. There's a rhythmic, very, very well timed. And if you actually time that out, you can see that it correlates with the patient's heart rate. That means the lung pulse is real. You had a question? End mode. So you're looking at only this line. This line right here, you're looking at this, and then you're looking at it over 1, 2, 3, 4 seconds. So what's going on at that point in time? So same spot, that doesn't move. And you're not looking at any of this stuff here, you're only looking at that one single point. So you want to know what's going on right there. So if the lung is sliding, you're going to see grainy stuff. If the lung is not sliding, you're going to see nothing. Nothing's going to be moving, right? Because everything's going to be staying still. And we'll show you what that looks like in a second. Okay. So this is lung pulse. You can see actually the heart rate in the M mode, all right? So if we slow it down, we can see it even more obvious, I think, here. You can change what's called sweep speed, and you see that it measures out to the patient's heart rate. And you can correlate that. If I have a lung pulse, I don't have a pneumothorax on that side. All right. So besides pneumothorax, what else causes no lung sliding? Hemothorax, well, you would see fluid in there, right? So you would see fluid on your ultrasound if you were to look. So why would air not be moving on one side or in a lung segment? Maybe, there it is. Right main stem intubation, right? And that's why we set it up like this, okay? So understanding that ultrasound is really, really great, but not everything that doesn't lung slide is a pneumothorax. And remember that anything else that causes consolidation can cause no air movement in there, right? If the alveoli are full, that section of lung isn't going to be moving or expanding, so you're not going to have anything there. But this is most obviously main stem intubation, right? Based on your history and everything, right? You wouldn't really, so one of the reasons that we talked about all of his traumas on the right side, you wouldn't expect him to have a left-sided pneumothorax, right? Because everything else was on the right side as well. All right, so lung pulse, we talked about a little bit before. And then we're going to talk, this is what's called lung point. So lung point is a finding that's very, very specific, 100% specific for pneumothorax, okay? So what this is the lung moving into the frame. You can actually see where the lung comes into contact with the pleura. It's not over here, but it is here. That means they have to have a pneumothorax, right? So that means absolutely they do. So if this patient got hypotensive, you're like, I know 100% he has a pneumothorax. His SATs get worse, he gets hypotensive. You can needle decompress that patient with 100% confidence that he has a pneumothorax on that side, okay? I'm not saying that's absolutely causing his hypotension, but he definitely has a pneumothorax on that side, okay? Questions? So anytime that you see the lung moving and some of it is not. See over here, there's no pleural movement here, and then there is over there. That's what you're looking for, where you can actually see the point that the lung is coming into contact with the pleura. All right, so this is what barcode sign is, okay? So this is, once again, coming through, our pleural line is here. This is that pleural line over here, and so instead of being really grainy, you see kind of that long streaks of white and black lines, all right? It looks more like a barcode than kind of that grainy picture. You guys see the difference? So that's going to be Sandy Beach. Once again, that's another barcode sign. And so those are the two next to each other. I think you guys can all see the difference on those, right? Takes a few to get used to. I'm not saying you're going to be experts at the end of this, but you can see the difference. And this is literally probe in one spot, take a look, take a clip, switch to M mode, take a look, you're done. This is a 30-second study, literally, on each side. And you're done with this, okay? And that answers your clinical question, do they have a pneumothorax on that side or not? Or in this case, is he right main stemmed? All right. So what was going on with this guy? He had no lung sliding on the left, but you couldn't find a lung point on that side. You did see a lung pulse. So what did you do? You pulled back the ET tube 2 centimeters 22. His SATs and his vitals improve, okay? So this is going to be helpful, I think, in a lot of ways. Because obviously it's pretty hard to hear lung sounds, right, when you're in flight. So they get the chest x-ray at the outside hospital, and your ET tube's in good position. Be like, none of that ever happened, right? You guys, they don't need to know about it. All right, no, I'm just kidding. So you would never do that. So just a couple quick points. The presence of lung sliding means no pneumothorax. Lack of lung sliding doesn't necessarily mean a pneumothorax, but it's a possibility. It's in your differential diagnosis. Use M mode to confirm no lung sliding or lung sliding, and lung point is 100% specific for pneumothorax, and lung pulse rules out pneumothorax at that point, okay? Questions? Lung pulse is going to be a little bit easier to see on the left side of the chest than the right. Lack of lung pulse doesn't mean a whole lot, but it's a very specific finding. Okay, let's go to our second case, and this is Sam's case. I remember Sam. I remember this case very, very well. So this is a 42-year-old lady, 42-year-old-ish lady with a non-traumatic aneurysmal, presumed aneurysmal subarachnoid. She presented to outside hospital, worst headache of her life, became obtunded during the time that she was there. She got intubated at the outside hospital for airway protection. She was initially hypertensive, which we would expect with the subarachnoid, right? Her heart rate's 70s, which we would expect. And her GCS was a 6T. It was a 6 before, 6 after. She was only withdrawing to pain. All right, so this is her CT. Is it working? See, it doesn't go up there, but it goes here. So this is her scan through. And then here's her classic starfish right there. I'll go to the next slide so you guys can see it. That's her starfish, so pretty decent subarachnoid. And what you're seeing here so starfish, right? That's kind of classic description. And these are her lateral horns, so she already got a little bit of early hydrocephalus. But the rest of her CT didn't show like severe hydrocephalus or signs of herniation, okay? So, you guys get there, and this is what her vitals are. So her heart rate's 65, her blood pressure is 130s over 60s, not on any vasoactives. She's intubated, SATs are 98%. GCS is now a 3T, because they've intubated her and paralyzed her. And her flight is planned for 50 minutes. What other questions do you have about the patient right now? Anything else you want to know before you fly? All right, let's go. So what's your blood pressure goal? No shift, no. This is what you've got. So you're going to go to another hospital where they can take care of this patient, so that's all you know. So blood pressure goes probably under 160. So she's hanging out where she needs to right now, right? So probably no intervention for as far as BP goes. Does that sound okay? All right, a couple head nods out there. All right. So this is what happens. So 15 minutes into your flight, heart rate goes down a little bit more. Heart rate's now 55, and blood pressure goes down. It's 80s over 40s. SATs are still good. Vent settings look okay, minimal, right? It's not good. And so, what do you want to know? Okay? Propofol, make sure it's not going in wide open. Fair enough. All right. What else do you want to know? No pupil changes. So her pupils are basically still like 1 millimeter from the propofol, let's say. Probably from the propofol. Oh my God, I love you. All right. So what's your differential diagnosis for hypotension in this patient? Why do you want to do the optic nerve sheath diameter?
To see if she's herniated.
See if she's herniated. You want to know if she has elevated ICP. So you've heard this shtick before, right? So the optic nerve is surrounded by a myelin sheath, which is contiguous with a dura. All right. So if you get swelling inside the brain, you're going to be able to see a dilation or a swelling of the optic nerve. All right. So this is us being able to look into the patient's brain essentially to see if there's elevated ICP or see if there's edema. Okay. All right. So what are the classic vital signs, or what classically happens when somebody herniates? And I'm guessing a lot of you have seen this happen in front of you. What happens to the patient? Pressure goes up. Pressure goes down. Pressure goes up, pressure goes, I mean, it's labile, right? Very, very labile. And then they get super hypotensive, right? So this patient, however, just kind of was like hypertensive and kind of gradually just drifted. So keep that in mind. I'm not trying to withhold any information from you, all right? So what else could it be? Propofol, somebody talked about. What else is in your differential? Sedation, could it be a pneumo? Probably not based on what we have, but it's in there, okay? What's your management plan? What are you going to do for this patient? Stop the propofol. Good. Okay. What else? Vasopressor. Okay. Why vasopressor? You're going with propofol being your leading contender?
Yeah.
Okay. Okay. What else? What are other options? Okay. 3%. So some sort of osmotic agent. So what about mannitol? You kind of wink and you went, no. Why not mannitol? it's already hypotensive, right? So 3% would be ideal in this situation. So I think it makes complete sense. Stop the propofol, give them some 3%, and do an ultrasound, right? All right. So that's your management plan. So you want to know what type of fluid you're going to give the patient, and this will help you delineate what's the best type of fluid to give the patient. You want to know if you want to give a vasopressor, an inotrope, or maybe something else. All right, so this is optic nerve sheath diameter. So this is, I stole it off the internet, of course. But really, you're going to use more gel than this, and you're basically going to just look on the patient's eye, both transverse and parasagittal. And what you're looking at is the eyeball, right here, right? You're actually going to turn the gain way up, and you can actually see like the lens and stuff up here. But we're focused on the optic nerve, which is back here, right? And that casts a little bit of a shadow here, all right? So that's what this looks at in maybe. Give me a second. There we go. So that's scanning back and forth, okay? And it didn't loop, of course. All right. So this is what that's going to look like here, okay? So we actually get a little bit of artifact on the outside, but here's our optic nerve, okay? We're going to measure it. So the classic measurement is 3 centimeters back from the back of the eye, and then it has to be greater than 5 millimeters across to suggest elevated ICP, being greater than 20 millimeters mercury, okay? So 3 by 5 index card is what we think about. 5 millimeters. Did I say centimeters? Okay, sorry, 5 millimeters. That would be a very large optic nerve. I'm just saying. That would be huge. He would definitely have elevated ICP. All right, so 3 millimeters back, measure across your optic nerve there. Not all the way across to avoid measuring your edge artifact. And that's kind of what you do there. And so in this patient, so you have an ultrasound, you do this, and his are 4.2 and 4.4 millimeters. So remember, greater than 5 suggests elevated ICP. So not so much in this patient. What's your next move? I'm going to give you a hint. So this is something that I got in sign out on this patient. So I remember the physician saying, you know, the CT... What's that?
For the record, you failed to tell me this on the phone.
I failed to tell you this on the phone?
Yeah.
Oh, you didn't get it from them at bedside report though either.
No.
So just to say. So I don't think the patient was hypotensive at the time, were they? I don't remember. When you called back. But either way, it doesn't matter. So they said the CTA took a really long time to do. It was really weird. We had to wait for the contrast to get to the vessels before, right? So what they do is they inject contrast, right? And they take a quick shot until they see the contrast, and then they scan, okay? So they do image, and they're just waiting. They're shooting like every few seconds, and it's not, contrast isn't getting there. Why is it? Yeah, exactly. So this patient is going to have this, all right? So this is kind of classic, especially for neuro patients, all right? So this is a parasternal long axis view. So we're looking from across the chest over here, all right? We're looking, this is the right ventricle, this is the left ventricle. This is the base of the heart, mitral valve is right here, aortic outflow is right here. So this is the LV. And we can see that the LV is only beating here and here at the base. So very, very classic for Takatsubos, okay? So this is what it's going to look like on parasternal short axis. So now instead of looking at it, the LV in its longest dimension, we're going to look at it in cross section. So you're kind of looking up the tube, okay? So what happens at the beginning of the clip, this is all the way down to the base. You see it doesn't go very much. And then we're kind of going back up, or sorry, this is the apex, doesn't squeeze very well. We're scanning up towards the mitral valve, and then it squeezes a lot better, all right? So apical akinesis with basal sparing is kind of a classic finding in Takatsubo. And this is probably the easiest to kind of figure out. And so this is the apical floor chamber. So you come over to the left side, you're going to look back up at the heart. So this is left ventricle here, right ventricle, left atrium, right atrium, interventricular septum. We can see that we're beating here. We can see squeeze here and here, but this part of the heart's not doing anything at all. All right. So just to go through a little bit of this anatomy, because that was really super fast, okay? And then we'll go back through stuff. So parasternal long axis, you start at about the second or third intercostal space, work your way down. We're going to have the indicator towards the patient's right shoulder. That's what this looks like here. And this is the image that you will all get your first time you do this, okay? So this is going to be left ventricle here, leaflet of the mitral, aortic valve here, right ventricle here, okay? So that's what that stuff is. This is going to be in diastole because the mitral valve is open. This is going to be at end diastole, end systole. We can see that the walls are much thicker. They've come together a lot more. And then now our aortic valve and mitral valve are both closed. It's end of systole. And this is what a normal clip looks like. All right. So we can see here it beats all the way here and here. So in a parasternal long, you're not going to be able to see the tip all the time. You're not going to be able to see the apex of the heart all the time, and that's fine. We're really focused at the base here, mitral valve, aortic valve, and we can also see like regurg and stuff there, okay? You can see that's a normal parasternal long axis view. So this is a parasternal short, so we stay in the same spot. We rotate 90 degrees towards the patient's left shoulder now. And this is a cross-sectional image, so you're like looking up, you're looking at the LV. So this is the LV here, all right? And then our RV is the kind of crescent shaped and wraps around our LV, and that's a normal appearance of an RV. Big muscular LV. And what are those guys right there? Those big muscular things. Papillary muscles. So that's kind of what the mitral valve opens with, right? And you can see, this is the clip here. So that's what normal looks like, right? So you see how much you're squeezing, and it's concentric. All the segments are moving. The septum moves, the free wall moves, okay? And you have to do this at multiple areas. You look at the apex, you look at the papillary muscles, you look at the mitral valve, you actually look all the way up the aortic valve. So there's a little bit more to this, but this is what normal looks like, okay?
So you're looking at that down, essentially looking from the top of the heart down.
Yep, so, yep, exactly. So you're doing it in cross-section, all right? So you're essentially like looking in through the tube, and you're seeing what it looks like at one in particular spot. So that's why you can't just do one parasternal short. You have to do it in multiple areas, because you're just like slicing a loaf of bread. And you're seeing what it looks like in each slice, okay? Versus the apical four-chamber, where you're really looking at all of it all at once, right? So here you're coming out kind of the anterior axillary line, looking back up at the heart, right? So because remember, the heart's oriented down like this, you're going to look back up. And that's what it should look like. And everyone's is super easy on this, okay? So those are the chambers there, right? So if this is LV and that's LA, what valve is this? Mitral. Excellent. Good. So right ventricle, right atrium, that's got to be our tricuspid valve, right? So we can look at all those valves and see how they're moving in this. This is where we get most of our information in this view, okay? And this is what a normal apical four-chamber looks like, maybe. And it doesn't want to go. All right, we'll have it again on another slide. And my video's down now. Give me just 1 second to reload this. Let me see if it works. What's that? No, it's just my video's not loading. None of them are. Oh, there goes one. I don't know why that one's not working. So anyway, you guys saw the normal what looked like before, but you can see here that the base is contracting, but that part is not. I tried to have them side by side, and this worked just a little bit ago. All right, so normal. All right, and abnormal. You guys can see the difference. So you can see, like, as it goes through on the left one, you can see how it becomes normal, but at the very beginning of the clip right here, it's not squeezing at all. And then our clip does not want to load. I don't understand how this worked an hour ago. Anyway. All right. So this is kind of the classic stress cardiomyopathy. So this is how ultrasound is going to be able to change what you do, right? So I remember Sam Collin, I think we gave some fluids and did some vasopressors, but it's kind of our finding, especially in the C-series, when we get these patients with bad head injuries, not just like a subarachnoid has a headache and maybe a little bit confused, but patients who are like getting intubated, they all have Taketsubos. Whether they're hypotensive from it or not, that's not necessarily true, but these patients almost always have some sort of cardiomyopathy from it, okay? And kind of the classic teaching that they talk about is you don't want to give these patients catecholamines. Well, this isn't the same thing as like the 45-year-old lady who like has some stressful event in her life and then like, oh, Dios mio, and then like goes into like Takotsubo. This is neurogenic mediated. So these patients do get catecholamines and they improve, right? You improve their cardiac output significantly by just giving them the chronotropy part, right? By increasing their heart rate from 55 to 85, you've done quite a lot. And then you also get moderate improvement in your EF. You're not going to be necessarily normal, but your cardiac output's probably going to double in these patients and improve your hypotension pretty significantly, okay? So just on like 0.02, 0.03 of epi, these patients will get significantly better. All right? So one of the worst things that you could do in this patient, Sam didn't know this, is give the patient a vasopressor, right? Because now you have this heart that's not beating, now pumping against more afterload, and that's only going to make the patient's cardiomyopathy worse, right? Like they can't squeeze against all that afterload. So this is somebody who really needs an inotrope.
If I remember right, her blood pressure did not get better at all. And I remember coming into you and saying, what was wrong?
And I said, well, you didn't have that little piece of information.
Looked at her heart, found out what was going on, and you put epi on her, and then she got better.
Yep, just took a couple minutes. And that's the thing is, you guys don't have the ability to kind of know that right now, but I get to cheat, right? Like, I'm like waiting for him with the ultrasound, like, Sam, come on now. You know, so we get to cheat a little bit, but I also had that piece of information about the CTA as well. All right, last case, I have till 3:30, right? Yep. Okay, good. Should be able to get through everything. So this is another interesting case. This flew with PHI as well, I'm pretty sure. So this is a guy, it was a really, really weird case. So he's an 80-year-old guy, he'd been at this outside hospital for like a week, and they were working him up for myasthenia, or he had some progressive neurologic weakness. He had been going for a while as an outpatient, then he got admitted, and then he kept getting like weaker and weaker, and his like vital capacity was like 200, and they didn't intubate him. Then it was like 100, and he was like barely breathing, and then he like had a cardiac arrest, right? And he got intubated that day. To cardiac arrest, and at the time of transfer, I didn't take the transfer call. I remember it was one of my colleagues, and she's the sweetest thing. You know who I'm talking about. And so, but it was evidently like the longest, most convoluted story, and she's just like, okay, and like I get there, and Dr. Duncan's like, so this guy's gonna come. I'm like, she's telling me the story. The nurse is trying to tell me the story. He's like, none of this makes any sense. What are you talking about? Like, why would they not intubate him, and why is he hypotensive now? Like, if it was a respiratory issue and they intubated him after his cardiac arrest, he should be fine, right? Like, whatever, it doesn't make sense. He's hypotensive, he's on some norepinephrine, whatever. All right, he'll get here, and we'll get him figured out. So, this is kind of what happens. This is a twist on the story. So, this is kind of what happened with us, but I'm playing it as the transport team. So, you guys get to the outside hospital, and he's desynchronous with the vent. He's not following commands, and it's desynchronous. Like, he is all over the place. He doesn't have like a normal respiratory pattern at all. And he's hypoxic. He's like satting in the 80s on 100% FiO2. So what's the first thing that you guys want to do? Yeah, thank God. Okay, good. I think this is like something that we talked about before, that Lewis talked about, and I completely agree. Like, get control of the situation, paralyze the patient, and figure out what's going on. So you guys give him 100 a rock, he settles out. He's on like minimal vent settings. Let's say he's on 5 a peep, 60%, setting 100%, looks like a peach. He's good to go, right? So really he's getting transported for chronic respiratory failure and had an event that he eventually decompensated, and you know, they just kind of ignored him for a while, right? But then en route he has a bradycardic arrest. And you're like, he didn't get hypotensive really before, maybe a little bit, like his blood pressure dropped a little, but it wasn't that bad. So a little bit of epi, like some chest compressions, and he comes right back. What was that? That was super, super weird. This is actually what happened to me. When the patient landed, within 5 minutes, all this stuff happened. And I was like, should have listened to that report a little bit better. I do not know what is going on with you, sir. So we'll say, for me, he got the rush protocol, but this is ideally what would happen with you guys, right? Is that he gets a rush protocol. Why did this guy arrest? Why is he hypotensive, okay? Because he is hypotensive. He's on norepi, but he's pretty stable on it, okay? So these are the things that we're going to go through. And this is some of it's going to be review, some of it's not, okay? So lung sliding or no? Lung sliding. So probably not a pneumothorax. So RUSH protocol is a rapid ultrasound and shock protocol. It's one of these shock hypotension protocols that's ultrasound based to kind of go systematically through the body to figure out why is my patient hypotensive. So basically what it does is it entertains a bunch of diagnoses and tries to rule them out systematically. All right, so pneumothorax, not so much. This is both sides of the chest. Right now, once again, now that he's not in arrest, he's satting fine on minimal vent settings. The respiratory doesn't seem to be a problem right now. So that makes sense, okay? All right. This is another ultrasound, or another echo, okay? So we can see LVs here, and we can see that we're squeezing all the way. Like those two walls, so the septum is here, the free wall is here, and you see how they squeeze and it comes all the way together? That's like hyperdynamic, okay? And if we do some, you could pretty much say in this patient he's going to be hyperdynamic and underfilled. I'll show you another picture in the parasternal short. So same idea. He's squeezing all the way down. There's basically nothing that he's not ejecting from his LV. And here's going to be your apical four-chamber. So squeezing all the way, those two walls come all the way together. His heart is beating fine. He's not having an MI, right? Cardiogenic shock is not his cause. His right side looks fine. This is not a PE, all right? He looks fluid down, though, for some reason, and that's a little weird. I mean, I guess the guy probably wasn't drinking a whole lot in the hospital. He was sitting there for a week, but why is he fluid down? Why is he hypervolemic? Because he's septic? Okay, I suppose. But as you see this, you can start to tailor your treatment a little bit, right? Based on this, what would you guys do? Start giving fluids, right? Pretty reasonable. Abdomen. And this is where things got interesting. So I'm looking at him, and so this is right upper quadrant. So this is going to be liver here, it's kidney here, and there's a stripe of black right there. And I went, huh, that's not supposed to be there. That's free fluid in his abdomen. That's really weird. And so now we're looking in the left upper quadrant. So spleen, I'm scanning through, and you can actually see kind of at the caudal tip here is going to be some fluid. So you don't necessarily see the fluid in between the two, which is kind of the classic teaching, but you always have to be wary of the fluid that's up there. So he's got fluid in his right upper quadrant and his left upper quadrant. His bladder, I don't have a good one, but this one is negative actually. There's no fluid. All right, so this is what you get. So he's hyperdynamic and underfilled, and there's free fluid in his abdomen. So that's like really, really strange, right? Like, why does this guy have fluid in his abdomen? Well, as we do a physical exam, I was like, wow, his belly's a little distended. And he has a peg. Did anybody tell me that he had a peg? No, no one told me that he had a peg. I don't think we knew that he... Did he have this before or after? So essentially what I did when he got there was I found a pocket of fluid and I stuck a needle in it. And all the nurses were like, what are you doing? We don't usually do this. So like, shouldn't you like CT him or like call a surgeon? He's like, no, 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 no. Ultrasound, I see the fluid, got it, blood. He had his peg the same day. And no one decided to tell us that. And his hemoglobin had actually dropped from 10 to 7. They gave him a couple units, and they never rechecked it. We got our I-stats there, and his hemoglobin was 4. That's low. Yeah, that is right. That is low. Good. Right? How long would it have been if we didn't have ultrasound to figure out what was going on with that guy? I'd have to get there, send labs, get the labs back, go, huh, why is his hemoglobin 4? And then the guy's arrested again, right? So this is what makes the difference, right? Or send him to CT, right? You don't have time to do that, right? So this is the hour that it really makes a big difference. And these are the cases where we talked about earlier, like finding the PE before you transport or while you're in transport so that you know to set up for VA ECMO, or finding the dissection so that the OR can be set up. We had a case not dissimilar to that where it was a STEMI. The guy was a STEMI, he had ST elevations, they took him to the cath lab, couldn't get the coronary artery open, blah, blah, blah. He came to us, he was going to go on VA ECMO, and I echoed him, and he actually had a dissection, right? Because dissections go retrograde in the coronary arteries. But no one ever shot a chest x-ray to see that it's widened mediastinum. Put that guy on VA ECMO, and he dies right there. No question, right? Shoot all that blood back up against his incompetent aortic valve, he's dead. So this is why bedside ultrasound makes a difference, right? You ask one single clinical question, and then you answer it, and it completely changes management, okay? So this is the best part. So like I have this syringe of blood and I'm like walking around with it because I think I'm kind of a badass, and which I was. I mean, come on. And the trauma surgeon comes up and it's somebody that like only does like part time, and he's like, "What did you do?" And I was like, he's like, just trying to make sure that I wasn't the one who did it. And he's like trying to use the ultrasound, and I'm like, dude, come on now. So if we can teach trauma surgeons how to ultrasound, we definitely can teach you guys how to ultrasound. He's like, yeah, I guess there was a bunch of blood in there. So he got his XLAP. He had a mesenteric bleeder that they overset, and he did fine, right? But how long, like the time course of this guy, he'd been bleeding for a while, and waiting to get a CT or get those labs back could have been very, very bad for him, okay? All right, so these are the take-home points. I think there's huge potential for ultrasound in the pre-hospital or in flight, right? Not every patient needs a complete study or complete exam, but Sam and I were talking today, and he's like, I just count the number of times that I would like ultrasound in my cases. And he goes, and it's at least 50% of the time where I'm like, I don't have all the information, and I think ultrasound could help me, right? These are some of the potential applications, all right? I think it's been studied, and I think we know that it can be effective and certainly doesn't harm patients and probably is beneficial. We might not be able to show a huge mortality benefit, but I think we can definitely have these case reports where if it was your family member, you'd probably want them to have ultrasound on board. And then I think these are all potential applications. Starting IVs, I think, for you guys would probably be one of the even more common ones. How many times do you get to another hospital and you're like, really? I'm going to fly with a 22? Like, come on, this is crazy. But there's other things as well, but these are kind of the things that we talked about today. Any questions about anything? That's my dog. Pickles. So you guys are going to have a chance to do some hands-on stuff today. I'll try and be around for it. Dr. Byers will be here as well. He knows a lot more about kind of the transport stuff of what's available. But the kind of the new IVIS with Sonosite is ridiculous, and I want one. I emailed my division director, and I was like, I want one. And we'll see if that happens. Probably not. But questions about anything? Yes.
What placement would you use to look for a dissection?
So a dissection, dissections are not going to be seen very frequently, but usually peristernal long is where you're going to see it. And so you'll look at the aortic valve and kind of just look at the aortic outflow tract. And so for dissections, what you really want to know is, has it retrograde dissected back into the aortic valve? And so a lot of the time you don't even need to see the dissection flap itself. You just need to be able to see that now the patient who has no previous diagnosis of any heart problems has wide open aortic insufficiency. And that's what I saw in that patient initially. Like, because before you put somebody on VA ECMO, you need to know that their aortic valve works, right? Because if it doesn't work, you throw all this blood back up into the LV and they die. So I was like, that is a ton of AI, right? You can also see pericardial effusion on that view, which he also had, and he saw a dissecting flap. So you're not even looking for the flap so much as the other findings that could be associated with it, the three main complications being pericardial tamponade, dissection of the aortic valve causing AI, and the dissection of the coronary arteries, which you won't see on ultrasound, but hopefully EKG you've gotten at some point in time. So those are the three big things that we worry about for cardiac complications of that. All right, sweet. Thanks, guys. I appreciate it.